Welcome to our webinar. We will begin promptly. Make sure your speakers are turned on. You will be muted during this webinar. Please use our chat to ask questions to our presenter. As a friendly reminder, this webinar will be available on our YouTube channel. You can download the PDF of today's presentation. Once again, welcome. We're glad you could join us. Welcome to our webinar. We will begin promptly. Make sure your speakers are turned on. You will be muted during this webinar. Please use our chat to ask questions to our presenter. As a friendly reminder, this webinar will be available on our YouTube channel. You can download the PDF of today's presentation. Once again, welcome. We're glad you could join us. American Latino Mental Health Technology Transfer Center was established to develop and maintain a collaborative network to support research development and dissemination, training and technical assistance, and workforce development for Hispanic Latino populations and communities receiving mental health services throughout the U.S. mainland and the Caribbean. We offer free technical assistance. If you want more information, please contact us. The National Hispanic and Latino MHTTC is under the direction of the Institute for Research, Education and Services in Addiction, IRESA, and housed at the Universidad Central del Caribe School of Medicine in Puerto Rico, and supported by the Substance Abuse and Mental Health Services Administration, SAMHSA, of the U.S. Department of Health and Human Services. As mentioned, the Mental Health TTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental health disorders on U.S. communities throughout its programs and services, and demonstrates that behavioral health is essential to health. Prevention works, treatment is effective, and people recover from mental and substance use disorders. You can learn more about SAMHSA by visiting www.samhsa.gov. And now our moderator.
Hi everybody, and welcome to today's webinar titled The Experience of Being a Non-Latino Mental Health Professional Who Works with Latinx Patients Providing Appropriate Transcultural Care. As some of you may remember, this is the continuation of the discussion we had during our previous webinar where Dr. Torres and Gabriela Moore, doctoral student of social work at the University of Texas in Houston, spoke about unpacking what it means to work with Latinx clients and families. So to let you know a little bit about our presenter today, Dr. Emily Maynard received her PhD in clinical psychology from Fordham University. Her predoctoral internship was conducted at NYU Bellevue Hospital Center in New York City, where she completed rotations in medical psychology, substance use treatment, and inpatient psychiatry. Dr. Maynard received her undergraduate degree in Spanish and Portuguese from Princeton University with a minor in Latin American Studies, and she was later a Fulbright Fellow to Brazil. Dr. Maynard is bilingual in Spanish and fluent in Brazilian Portuguese. Dr. Maynard's dissertation research examined the experience of being diagnosed with bipolar disorder in emerging adulthood. She's particularly interested in diagnostic issues among individuals with severe mental illness, substance use disorders, and personality disorders. The majority of her clinical training has focused on providing care to Latinos and other immigrant groups, and she is versed in family, group, individuals, and individual psychotherapy. She pragmatically draws from behavioral psychology, health psychology, psychodynamic psychotherapy, and humanistic existential perspectives in providing care to her patients. In addition to the Hosford Clinic, Dr. Maynard works off-site at the St. George Family Youth Center, YMCA, in Isla Vista, providing psychoeducation and support to Latino youths and their families. So now that we know our presenter, let's get to know our audience, and we'll start with our poll questioning. And our first question is, do you currently serve Hispanic and Latino populations with any serious emotional disturbance? And 80% of our participants say yes, 20% say no. Are you planning to serve Hispanic and Latino populations in the next 6 months? And we have 94% say yes, 6% don't know. What is your current professional role? And we have 27% social worker case manager, 45% counselor, therapist, psychologist, 5% faculty, research, or student, 6% government official, policymaker, and 13% other. What type of setting do you currently work in? And we have 11% university higher education, 43% treatment, 17% government, and 30% other. So now we go to our pre-questions, our pre-test. Racism is not an issue in Latin America when compared with the United States. And we have 7% true, 93% say false. Next question. There are a higher percentage of Latino social workers than Latino psychologists. And 78% say true, 27% say false. And our last question, Latin America is considered the most violent region in the world. And we have 17% say true, 83% false. Okay, so thank you everybody for participating. Now that we know our presenter and our audience, I'm going to pass over the controls to our presenter, Dr. Emily Maynard.
Okay, can you hear me now, Daddies?
Yes.
Okay, and am I also, you can also see me?
Not yet.
Not yet. Do you need to see the visual too? Let me see.
Okay, there we go. Yes, we can see you and we see your presentation.
Okay, thanks so much for the introduction. I'm really happy to be here this morning and to see that there's quite a good turnout for this presentation. So I'm guessing that this actually is hitting a chord for some folks besides myself. So the real rationale behind the presentation is just that, oh, sorry, I'm having trouble with the control there. We all know that about 18% of the US population is Hispanic or Latino, and the number is only growing. Only about 5% of American psychologists are Hispanic or Latino. I had from a previous presentation about 3% of American social workers being Hispanic or Latino. However, I understand that this number has increased, and actually there are more social workers now percentage-wise than psychologists who are Hispanic or Latino. But because the number of providers or percentage of providers that are Latino or Hispanic are still lower percentage-wise than the percentage of patients, it's likely that many Latino patients will be served by psychologists and other mental health providers who are not Latino, and who may or may not be unfamiliar with the cultural norms and expectations of their patients. So this is just a geographic map showing some of the distribution in terms of a percentage of counties that are Latinos. So you can see the red areas for historical and geographic reasons have a higher percentage of Latinos. So in the research and often in practice, there's a perceived value of matching race and ethnicity between health providers and consumers. However, findings have varied with regards to the impact of racial or ethnic matching in terms of using services and in terms of the outcomes of services. We don't really have a clear research result that says, yes, we should be matching clients with providers by race and ethnicity. But even if there were compelling evidence that racial or ethnic matching could improve treatment outcomes, there simply aren't enough Latinx psychologists or other mental health providers to ensure ethnic matching with our patients, given the changing demographics in the United States. So this presentation comes from the idea that actually non-Latinos can and should provide culturally competent mental health services to their Latino patients, given that they have the appropriate training and background. A lot of non-Latino psychologists or social workers, other practitioners may already have significant exposure to Latin American languages and cultures. Spanish is the most taught second language in US schools. Almost half of university students who take a second language are studying Spanish, and this makes about 800,000 college students that were enrolled in Spanish courses. So we can assume that actually a large number of people in the United States that aren't Latino have some exposure to the language, may have some exposure to the culture. So this presentation is geared towards non-Latino mental health practitioners who might be able to provide services in Spanish or have some familiarity with Latino cultures, but are uncertain how to provide the best care to Latino patients. So I'm assuming that most of you are already providing some care to Latinos and that you're here because you just want to refine some of what you're doing and make sure that what you're doing is consistent with best practices. So Dr. Urabici shared a little bit about myself. I'm a licensed clinical psychologist. I'm no longer a postdoctoral fellow. I work at Counseling and Psychological Services at the University of California, Santa Barbara, where I'm a staff psychologist. We are a Hispanic serving institution. We're also an Asian American and Pacific Islander serving institution. Most of the patients that I work with are people of immigrant backgrounds. I do occasionally use clinical Spanish and Portuguese with the students that I work with. However, they're predominantly English speaking, given that it's an American university. I was fortunate enough in my clinical training to receive supervision in Spanish, to work with Latino patients in Spanish, and to have supervisors from a variety of different Spanish-speaking countries, such as the Dominican Republic, Mexico, different South American countries, Spain, and Puerto Rico, which is not a country, but it is Spanish-speaking. I also lived in Latin America for a total of 3 years. I lived in the Southern Cone region in Chile, Argentina, and Brazil between 2000 and 2006. I was a Fulbright Fellow to Brazil in Latin American history, and I majored in Spanish and Portuguese, as was already mentioned. So the themes of my presentation today are going to be La Diversidad, the diversity of Latin Americans in the United States, trauma and history, understanding the social context of psychopathology, el lenguaje, using language in clinical practice, cultural values such as personalismo, familismo, machismo, marianismo, so understanding the importance of personal connection in our therapeutic work with Latinos, appreciating the role of family in supporting psychosocial functioning, and also questioning some apparent dichotomies in masculine and feminine roles. Finally, I'm going to talk about forming a commitment, a compromiso, to working with this community. And I'm just going to state, I am not Latina. So my background, I'm Anglo-American. I do speak Spanish fluently. I've lived in these other countries. My knowledge is necessarily limited. I don't have the lived experience of being Latino in this country. So I'm speaking from what has been helpful to me as a clinician and also based on what research says about working with Latinos. But I'm very open to hearing others' perspectives and to learning from my patients as well as my colleagues. So just a brief overview of the region. So the region of Latin America and the Caribbean includes 20 countries. Spanish and Portuguese are the most widely spoken languages. Also, French, Creole, English, and numerous indigenous languages are spoken across the zone. In the United States, however, about 75% of Latinos come from three groups: Mexico, Cuba, or Puerto Rico. This chart shows the percentage of Latinos in the United States by different countries or places of origin. So we can see that predominantly in the United States, for historic and geographic reasons, Mexican Americans are the largest Latino group, then followed by some Caribbeans, by Puerto Ricans, Cubans, and Dominicans, and then other specific countries. Now, it's important to note that these are national breakdowns. When we look at California, where I live in practice, it's about 83% Mexican. I used to live in practice in New York City, which I believe has a much higher percentage of Caribbean Latinos. So it's important to keep in mind, even though nationally Mexicans are the largest Latino group, there's a lot of diversity by region, and between countries, there's a lot of diversity in terms of cultural values. We'll talk about that. So when we think about Latin America, all major US racial categories are represented in Latin America. There are people of European, African, Indigenous, and Asian descent. There are also significant numbers of people of Middle Eastern and North African descent. However, race and ethnicity functions differently across Latin America than it does in the United States. This doesn't mean that there isn't racism, but that often racial boundaries are not as clearly defined as they are in this country due to earlier histories of interracial mixing, called mestizaje in Spanish. Racism does exist in Latin America, it just works a little differently. Elites across the region tend to be of European descent, and in different countries, the darker your skin, the more indigenous or African descent you are, the more likely you are to live in poverty or to be working class. But just to give a visual idea of the diversity of Latin Americans, here are some famous Latin Americans of diverse races and ethnicities. I just want you to take a minute to look at these. Some of these are figures, older figures, but I wanted to get a real diversity of what we would consider American racial groups. So we have Don Francisco, who is a television host. We have Shakira, world-renowned singer. Celia Cruz, another singer. Michelle Bachelet, who was the former president of Chile, and Alberto Fujimori, who was the former president of Peru. Don Francisco is from Chile. He's of German Jewish descent. There are large Jewish communities across Latin America. Shakira is of Middle Eastern and European descent. Celia Cruz is of African and mixed race descent. Michelle Bachelet is of mostly European descent, and Alberto Fujimori is of Japanese descent. There are large numbers of Japanese immigrants that have lived for many generations in Peru, in Brazil, and other parts of Latin America. And these are just some pictures to represent the geographic and cultural diversity of Latin America, where we see landscapes ranging from pristine wilderness, deserts, Patagonia, mountains, plains, the sea. We also have very large cities, some of the largest cities in the world, with examples of mostly European style architecture. And coexisting across the region with more traditional lifestyles with indigenous communities that speak their own languages and follow their own traditions. So when we approach race and ethnicity in psychotherapy with Latinos, we should keep in mind that often country of origin, rather than race per se, can be a stronger marker of identity for Latinos in the United States. Don't assume that the way someone looks is the way that they identify or is what their genes are. So someone from Latin America and also someone from the United States could have dark or light skin and not consider themselves to belong to the racial or ethnic group that they would belong to in the United States. Within Latin America, class divisions tend to be more prominent than racial divisions. And there's a long history of class-based movements and revolutions in Latin America, including the Cuban Revolution, Hugo Chavez and his government in Venezuela, and there's current class-related protests in Chile, just to name a few places. Also consider when you're working with Latin American patients that there can be considerable differences between people from urban areas and people from rural areas, also between people who have indigenous identities versus African, mixed race, or European identities. I found it helpful to acknowledge my own racial or ethnic identity in working with not just my Latino patients, but with other patients. Especially if you speak Spanish and are not Latino, and if you're like myself and don't look stereotypically what people expect to be Latino, patients will have curiosity about how you acquired Spanish. And I've found that if I don't answer questions about language acquisition or race or ethnicity, that I might be perceived by my patients as being hostile or strange, or I actually might make them more fearful and doubtful if I don't say, oh, this is why I speak Spanish. So I found it's helpful to just give a brief explanation and move on of like, oh, I lived in Chile and Argentina for a few years. And I often will say something like, and I keep learning Spanish because I never stop learning Spanish. I work with a lot of Spanish speakers. So in psychological practice with diverse individuals, there's this concept of cultural humility, which is the idea that when we approach a culture, even our own, it's helpful not to assume the position of an expert, someone who knows everything, but rather have an open mind to learning more about different cultures. So this is cultural humility. And it's important to recognize the limits of what we know about the cultures of others, but also at the same time to not just accept, oh, I'm ignorant, I don't know anything about Peru, but to educate ourselves about the countries and regions that our patients come from. With the internet, this is really easy to do. It's really easy to pull up a Wikipedia article and learn more. And I'm just including a photograph here of a city in Ecuador called Cuenca, because when I was working in New York, I worked with a number of families at a family clinic, and they were all from this particular city in Ecuador. And I was curious, like, why are we seeing this immigration pattern? Why are people leaving this place? What's it like? So I did some of this research. I also talked to some people that, some other psychologists who had spent time in Ecuador, and they were able to give me a little bit more of the context in terms of immigration patterns. So in working with Latin Americans, I've found it's also very helpful to have some awareness of the history of the region. And this is in part because Latin American cultures tend to place more importance on the past than white American culture does. White American culture is very present and future oriented. Also, maybe it's obvious, but immigrants don't leave their past at the border. Just because you come to a new country, just because you have a new life, or you speak a new language, doesn't mean that what happened before you immigrated was insignificant. And making space for talking about the past and about one's home country or the home country of one's family can be really important in psychotherapy. So to just give you a very brief background of some of the recent as well as longer term history of the region, I find it, because I did study history, I have a background in studying history, that can really ground some of the work I do in terms of understanding intergenerational cycles, in terms of understanding what are the factors that promoted immigration. So many Latinos in the US are coming, especially recent immigrants, but even people whose families have been here for generations are coming from countries with recent histories of civil war, oppressive or authoritarian regimes, and economic crises. Latin America is currently the region in the world with the highest homicide rate. And there are large percentages of Latinos that have been exposed to political violence and other forms of trauma. This map from the UN shows countries with homicide rate of different countries, where the redder the country, the higher the homicide rate. And although we don't have a lot of data for Africa and the Middle East, we can see pretty clearly that Latin American countries are taking the lead in terms of homicide rates. And why is this important? This is important, obviously, because a lot of people that are coming to the United States right now from this region are coming to escape violence. Some of this violence is driven by drug trafficking in the Andean region and in Mexico and Central America. apart from the violence across the region, another influence on immigration is just that it's become much harder to immigrate, that there's a hard line in immigration by our US government, leading to detention of children and families at the border, also deportation of long-term undocumented immigrants. I've worked with several university students here whose parents have been deported in the last year. So I'm really seeing the impact of some of the US policies on immigration on the mental health of my patients. Also, we have more restrictive asylum policies than we ever did before. So people who previously may have received political asylum are unable to do so, despite the region still having high rates of violence and political unrest. So currently, if you listen to the news, you're probably aware of the collapse of the Venezuelan economy and political system, that this has been ongoing. In 2016, Fidel Castro died in Cuba, and although there was initially the belief that Cuba would become more open to free markets, it's continued under the leadership of his brother, and we're really just not sure what's going to happen with Cuba in terms of US-Cuba relations. Since about 2002, Argentina has been in an economic crisis. Brazil has also been in an economic crisis for the last 5 years, and this is significant because Brazil is one of the largest economies in the world. Also, we've had recent, very significant and destructive hurricanes in the Caribbean, Hurricane Maria, Hurricane Dorian, who have directly impacted even some of the people that work for the Latino and Hispanic Mental Health Technology Transfer Center, which is based in Puerto Rico. If we go back a little further in the recent past, we know that there have been civil wars across Central America in the 1980s. People are still experiencing the repercussions of this. Often I work with university students whose parents came to the United States from Central America in the 80s and 90s to escape political violence. Still have the ongoing influence of Castro's Cuba. There were authoritarian dictatorships in Chile, Argentina, and Brazil in the 70s and 80s, just to name a few places. And it's important to note that in a lot of these non-democratic governments, there has been US support across the region. So US funding, US military aid to non-democratic regimes. So if we go even further past, the Mexican-American War was a watershed moment in US-Latin American relationships where the United States actually invaded Mexico, got as far as Mexico City, and then Mexico and the peace treaty signed over large territories consisting of the current states of California, Nevada, Utah, Arizona, and New Mexico. This is reflected in the place where I live in Santa Barbara, California, where nearly all the place names are Spanish language names. Also a little later, the Spanish-American War in 1898. Not a lot of people know about this, but this was a war that Spain lost, and they lost some of their overseas possessions to the United States, including Puerto Rico, which is still a US territory, the Philippines, which was a US territory and now is an independent nation, and also the territory of Guantanamo Bay in Cuba, which is why we have this one military base in Cuba. So thinking back even longer ago, we have this very similar to the United States, a history of European colonialism, history of forced labor and conquest of indigenous communities. In Santa Barbara, these are called the Chumash. We also have had the widespread enslavement of people of African and indigenous descent, and extractive economic systems across the region, very similar to the US South, that were based on large-scale production of commodities such as sugar, cotton, rubber, bananas, and gold. So what does this all mean? This means that this is a region that's had a turbulent history, and that there have been various events across history that could be considered traumatic. And so as clinicians, when we're working with patients, we always are inquiring about the impact of family history on the patient's functioning, and we might be curious about intergenerational transmission of trauma. So a question we can ask is, what would be considered pathological? So for instance, paranoia, this is a common symptom of psychosis, but when someone is really cautious and scared and has grown up in an oppressive police state, This might be adaptive and normal functioning versus a sign of psychosis or individual psychopathology. So that's always something to keep in mind, is how normative is this person's suspiciousness. Also, in the context of current immigration policy and raids, some suspiciousness of institutions, reluctance to give names, reluctance to provide information to mental health care could also be, a response to the current immigration situation. There's also the presence of what's called ethno-racial trauma, which is trauma, it's vicarious trauma that someone experiences due to belonging to an ethno or racial group that is discriminated against and marginalized in the community. So this would apply to, for instance, middle class, upper class, professional Latinos who are US citizens, who are not afraid of being deported, but when they watch the news and they see pictures of Mexican families in detention centers and they realize, wow, that person has the same last name as I do, there is this impact of witnessing trauma against the group that you belong to, even though you are not directly experiencing that. Another thing to consider in terms of what is psychopathological is that I've found across my work with Latino patients that there can be a greater openness to paranormal experience, a greater willingness to talk about ghosts or witchcraft, angels or UFOs. And this might initially be seen as psychotic behavior, but it's important again to consider in the cultural context, are these normative beliefs, or are these getting in the way of someone's functioning? Are they causing a lot of distress? And then we might consider that to be, more of mental illness. There's also different kinds of non-institutional religious practices across the region that we might consider witchcraft, things like Santeria, curanderismo, voodoo, candomblé. These are different names for non-institutional religion. So I'm going to speak a little to use of Spanish language in treatment. And I know that not everyone attending here speaks Spanish, but I think that there probably will be enough of you that can relate to some of what I'm talking about. I do firmly believe that non-Latino Spanish speakers can treat Latinos who speak Spanish with sufficient training and supervision. However, we should do so with a few caveats, that if we are bilingual practitioners, we may have learned Spanish in regions different from the regions of our patients. So for instance, my Spanish is predominantly from the Southern Cone region, and most of the patients I worked with in New York City were Caribbean. Most of the patients that I see in California are of Mexican descent. So just from the get-go, yes, we speak the same language, but there are going to be some differences in how words are used and slang that's used, and we should be aware of that and approach that from a position of humility and curiosity. It can be helpful to acquire what I call a sort of neutral or transnational Spanish to use with Spanish speakers in the United States, as well as familiarizing ourselves with country-specific vocabulary and slang. And I've found several online resources for clinical language. I'm just including a link here. So when I supervise students, and I do have some that are Spanish speaking that I supervise in Spanish, but when I supervise student clinicians, I talk a lot about how you have to learn clinical Spanish just in the same way that we have to learn clinical English. So when we begin our training as practitioners, I didn't know what all of the clinical vocabulary meant. I didn't know exactly what it meant to have psychosis, what it meant to have obsessive compulsive disorder. I didn't know all of the neurological terms like sequela or lesion in English. And so it's to be expected I wouldn't know those in Spanish, and I have to put intentional work into learning clinical Spanish. I've found that English-Spanish dictionaries can be fine, but they're not as detailed or comprehensive as Spanish-Spanish dictionaries. So I really encourage people that are using Spanish clinically to invest in the Spanish-Spanish dictionary, because that will also have more regional variations. So when we use Spanish as mental health providers, we're going to also use some lay vocabulary. Just how do our patients describe emotions and ordinary experiences? Just like when we work in English, we don't use all of the clinical terms and diagnoses all the time with our patients. We don't always go in saying, have you had a flat, like what's your affect seems flat today? Like that's not the word that we wouldn't use that kind of vocabulary. And similarly in Spanish, we don't want to just use clinical vocabulary. So some instances, some examples of lay vocabulary to describe emotions would be little phrases like que pena, like how sad or what a pity. Or what I hear my patients say a lot is that me dio mucho coraje, something made me very angry. Another common phrase is quiero desahogarme, I want to get things off my chest. When I ask people, why do you come to therapy? Porque quiero desahogarme. And then again, we do have that clinical vocabulary to describe disorders and symptoms. So words like trastorno de déficit de atención, which is ADHD, other specific diagnoses like depresión, pánico, ansiedad. Estado de ánimo is the mood, cómo es su estado de ánimo. Lesión cerebral is a head injury, a derrame is a stroke. And this clinical vocabulary can be fairly easily acquired with some Spanish language dictionaries. Also, there are specific medical dictionaries that I found helpful when I was working inpatient. So some other examples of when you work with people from different regions, you start to learn the slang of different regions. So working with patients from Puerto Rico and the Dominican Republic, I started to hear words like hearing a child described as a tiger. And this didn't mean that the child was actually a tiger, but it was like a rambunctious child. Another word that I would hear was revolú, which found out meant, oh, it was a big mess, it was a confusion. Another term was espérame un chin, where a chin was like, wait a second. I'm just giving these examples because these were things I had to learn and recognize in my patients. And there's different ways to approach this clinically. You might want to ask directly in the moment if you don't understand the gist of what they're saying to clarify. Say, oh, you know, like my Spanish is a little different than your Spanish. Can you tell me what that means? If it doesn't seem so important to the theme of what's being talked about, you might also just wait until right after the session. Take a note for yourself. Look it up in a dictionary. This is what is involved in this continual practice of Spanish. I just have some other examples from Mexican Spanish. So whereas in other parts of Latin America, when someone said, I will see you, I'll do it ahorita, it meant right away. When I would speak with people from Mexico, if they said, I'll do it ahorita, it meant at some point in the future. So that could lead to some confusion for me where I'm thinking, oh, we both speak Spanish, but I'm thinking they're going to do something right away. And they're telling me like, oh, there's no urgency. So in conclusion, bilingual practitioners need to engage in continuous self-education and practice of Spanish. And this is what I mean when I say, you know, I lived in these countries, but I keep learning Spanish. I have several dictionaries in my office. I'm very committed to continuing to learn Spanish from my patients and from my colleagues. What we don't speak gets lost. So we have to take advantage of opportunities that we have and seek out other opportunities to keep up our Spanish or Portuguese or other languages. Watching Spanish language films, reading books, listening to music, or consuming other Spanish language media can be really helpful in this. And it also clearly demonstrates to our patients a commitment to the culture. If we are learning the language or if we speak the language already, it's hard to dispute that, yes, I have a commitment to working with this group when you speak the language. However, even if you don't speak Spanish, there's some things that are important to keep in mind. And if English is your only language, just go into interactions with the knowledge that sometimes emotions are conveyed differently in different languages. And sometimes the one's first language can have a stronger affective charge than the acquired language. Where the language learned in childhood is more of the language of emotions, it's a language of attachment, of relationships. The language learned in adolescence or in the school setting, in the work setting, which is often English for Latino immigrants, then that's the language of the professional world, the language of logic, of intellect, and is going to have a different affective charge. One technique that you can do is that you can encourage your patients to switch to Spanish when discussing emotionally charged material. Even if you don't understand it. I had a supervisor that would do this. She was Turkish American, and she would have a patient say something in Spanish and then ask them to translate it back to her so that she could observe the body language, hear the tone of voice, get a sense for what was the emotion behind it. If you're bilingual and speak a language other than English or Spanish, you can use what you already know about being bilingual in your practice. So just like that Turkish supervisor, she knew what it was like to be bilingual. She was aware of the different affective responses in different languages, and she could apply that to working with people even whose first language she didn't understand. If you're bilingual in another language, you will have a shared experience of bilingualism and biculturalism. So I have a colleague here at the Counseling Center from Taiwan, and she speaks Mandarin and Cantonese and English, and I speak English and Spanish and Portuguese. And even though we only share English, we have some similarities in terms of being bilingual, trilingual, and the work that we do with people in languages other than English. Returning again to this idea of cultural humility, if your patients are using language in a different way, if they're using Spanish or English in non-standard ways, it's not your job to correct them. It's your job to match them and to learn from them, that this is always continual learning that we do. I'm going to talk about a few themes related that come up across the literature on working with Latinos. Personalismo or personalism, sometimes this is referred to as formal friendliness, is the idea that Latinos may expect a more personalized approach. They may expect a little more affection, more of a personal interest in them. You can convey this as a clinician by using warmth, by asking about family members, and by recognizing it's not that boundaries aren't present with Latino patients, but that boundaries are different. So it's more usual for Latino patients to engage you in some small talk before getting into what brings them to therapy. And we shouldn't interpret this as, oh, they're avoiding what they're really here for, but rather cultural norms that first you make some small talk, you ask about family, and then you go into the purpose of the meeting. If you speak Spanish, you may be aware that there's more formal Spanish and less formal Spanish. So I use as just a general principle the more formal usted when I'm working with patients, especially because Latinos tend to expect me as a psychologist to be in a position of authority. They're giving me some authority and they're anticipating that this is a professional relationship. In general, Latino cultures have a greater focus on family functioning rather than on autonomous individualism. I know it can be a stereotype of white American culture. Of course, white Americans also value family, but a lot of our psychological theories prioritize individual over social functioning. And this just might not feel congruent with cultural values. Family therapy can be a very useful modality for Latinos. There's extensive research and written about family therapy with Latinos. And ways to acknowledge family role in therapy include asking your patients about significant family members. When I worked in this youth center, I would always tell the children or teens, like, say hi to your mother for me. I would make sure I knew who the mother was. That's a way to always indicate, I see you and I see your family. Also, you can allow parents of infants or small children to bring their children into psychotherapy with them as long as they're not overly disruptive, but that could be a therapeutic opportunity. Finally, I think it's important to acknowledge that there are sexist practices in Latin America. This term machismo is commonly used in English as well as in Spanish. But that in the United States, we also have a history of sexism and differential treatment by sex and gender. It's not limited to Latin America. So if we get overly fixated on, oh, this is a machista culture, the patient is acting in this way because of their machista cultural values, I think there can be this tendency to exoticize Latino patients, to blame the culture, and to not recognize that our culture probably has a lot also that's problematic when it comes to gender. And that terms like machismo, or the female equivalent is marianismo, which is this ideal of a woman being submissive, being pious, being focused on family, that these are social ideals, but they can be stereotypical ways to view gender. And in contrast to these stereotypical ways, there's a long history of female university education in Latin America, that most public universities in Latin America admitted women long before universities in the United States did. There have been more female presidents in Latin America than in the United States. There's higher percentages of women in STEM fields in Latin America than in the United States. And in some parts of Latin America, masculine gender norms actually allow for greater range of emotional expression than among white Anglo men. So I just bring these points up as some examples of, it's not so simple as this is a machista culture that oppresses women. This is a, as with any culture, there are nuances, there are flaws, and then there are places that they may be doing a better job than we are. Also, I found a lot of Latinas and Latinos are very critical of social expectations for women. So the last thing I'm going to talk about is what I call el compromiso. For those who don't speak Spanish, that's not a compromise, but rather a commitment. And I think for non-Latinos, it's important to demonstrate an ongoing commitment to working with Latinos. I don't have a Latino last name. I'm not obviously someone who speaks Spanish, so I have to demonstrate that I have a commitment to working with these groups. And of course, speaking Spanish is one way to demonstrate that commitment, but so is showing up in the community, showing up for our patients. One way we can do this is we can also continue to learn about the region. We can take university level classes or extension classes in Spanish, take classes on Latin American history and culture. We can visit Spanish-speaking neighborhoods in the US, like Spanish Harlem, parts of Miami, parts of Los Angeles. We can also travel to Latin America. A lot of us are professionals. We have some disposable income. We can travel, and maybe next time we don't go to the resort where we only see other foreigners. Maybe we go to a large Latin American city, go to Mexico City, go to Guatemala City, see what it's like to live in these large cities in Latin America. We can continue, like you're doing, to seek out professional opportunities to train and receive supervision in Spanish. For instance, my internship year, before I received my PhD, I was on a Spanish language inpatient unit. I also had Spanish supervision. I did neurological testing in Spanish. As a postdoctoral fellow here in Santa Barbara, I worked with Mexican and Central American youth and families. And I mentioned these opportunities because each of these was something that I had to intentionally seek out, that I had to indicate, I want more experience working in Spanish. I have these skills. This is what I want to learn. And I found that without that, it would have been very easy for me to just work in an English-only context, even though I speak Spanish. So I mentioned before, I'm currently employed as a staff psychologist at UC Santa Barbara, which is a Hispanic serving institution. About 31% of the students that we serve at our counseling center are Latinx. I also provide Spanish language supervision to psychologists in training in the PhD program here. I've really benefited from having Spanish language supervision, and it's a real privilege to be able to continue that with the next generation of psychologists. I encourage you to continue to educate yourself about recent and past political events in your patient's countries of origin. So lately on the news, I've been hearing a lot about Bolivia. Is this a coup d'etat? Is it not a coup d'etat? Hearing about protests in Chile. We should keep inquiring about the impact of the immigration experience on our patients. And another way to demonstrate commitment to working with this group is to be present at public events in the Latino community, such as this folkloric dance performance in Santa Barbara, Christmas events, art exhibits by Latino artists, music concerts. I went to a music concert earlier this week with 2 Brazilian musicians, and I think every Brazilian that I know in Santa Barbara was at that concert. Also, we can frequent Latino-owned businesses in our community. We can acknowledge important holidays and traditions with our patients. So the countries I lived in don't celebrate Day of the Dead, but Dia de los Muertos is very well known in the United States, given the large percentage of Mexicans in this country. And so when I worked at a youth center that had primarily Mexican and Central American students, we created an altar for Day of the Dead. Another way that I demonstrate my commitment is in my office space. I have items, so this is actually where I am right now giving this presentation. I have maps. I have a map of Mexico that's very colorful. I have a map of South America where I lived. And I find that students, when they come into my office, they immediately gravitate towards the maps if they have family members that from those regions. And then it really opens up conversations about, oh, where is your family from? What part of Mexico? What part of Peru? On my other wall, I have a map of Southeast Asia because we have a lot of students from Asia. And the same thing, it can lead to conversations about immigration, open up those discussions. And I also have items that are representative of my own cultural background. And if you can see me presenting, there's a weaving on my wall in the back. And I love fiber arts, I love textile arts, and I actually created that weaving myself. So I have things that are personal, important to me, as well as things that reflect the culture of my patients. So with that, I'm going to end. I'm open to questions, and I'll await further instruction from the organizers. So thank you so much for having me today. I know that I spoke very quickly and we had a lot of material to cover, but I hope that I've given you some things to think about and that we can continue this discussion.
Thank you, Dr. Maynard. That was a wonderful presentation. And we do have some questions from our audience that I'm going to share with you.
Great. How can I see them? Are you just going to read them?
I will. Okay, so we have one question. Do certain theoretical orientations enhance practice with Latino youths and families?
Great question. I've heard mixed things in the literature. So on the one hand, often people that haven't accessed mental health services before want solutions, want the therapist to be directive. They want to come away with something tangible at the first appointment. So this isn't specific to Latinos, but there are a lot of Latinos that I've worked with that have never seen a mental health provider. So in that case, I am aware of what am I giving to them, and can I give them something more concrete? Can I give them some skills? Can we present maybe some CBT concepts? Can we do something like a family genogram? And that can enhance treatment buy-in of like, oh, I'm talking to someone who knows what they're doing and I want to come back. On the other hand, I've also found that more psychodynamic approaches, considering the patient's past, the history of the region, the history of the family, goes over very well because cultural values emphasize family and history. And also across the region, psychoanalysis has been very influential, especially in Southern South America, in Argentina, in Brazil, also in Mexico. And although most of my patients are not from upper class families that have accessed psychoanalysis in those regions, it's just important to note that there is this history in the region of practitioners primarily providing psychoanalytic services.
Mm-hmm. Thank you. So we have another question. In working with youth, my experience with Latino teen males has been that they are sometimes treated as the man of the house, even though they're minors. How do you approach working with mothers of these youths regarding family dynamics and rules and expectations?
What a great question. Well, I guess I would wonder how that situation came about. Is there an absence of the father? Is there actually no father? Is this a single mother? In which case that is pretty common in families run by women, that an older male child will take the role. Is there also the situation that the parents don't speak English, they only speak Spanish, the children speak English and Spanish, in which case it's very common for children in immigrant families to assume the role of the translator and the interpreter and to take on responsibilities that generally children don't take on. So like making doctor's appointments, being present at the doctor's appointment, and even though the doctor's supposed to provide an interpreter, that the child may end up interpreting, or maybe the one that ends up calling the school. And so I think sometimes it is helpful with families to intervene in the sense of reminding the parent what is their role, what is their child's role, applauding the child for the things that they have been able to learn, because that is going to be a strength, that child's going to be able to negotiate the adult world in a different way. I've avoided saying parentifying, but that may be a way to conceptualize it as well, is that this child may have been parentified, and really through no fault of the parent. I mean, no parent decides like, I'm going to have a hard time learning English and I'm going to be working 3 jobs, and so therefore my child's going to do things. But sometimes the situations that families find themselves in are very challenging. And so it may also be then involving some case management. Can we get some respite for the parent who's caring for these other children? Also, it can be pretty normative in Latino families that children will pitch, like older children will earn money for the family. And that's the expectation, is that everyone contributes to the financial well-being of the family.
Thank you. Thank you. Great. How do you approach suggestions such as explaining or suggesting or encouraging a client to switch to their primary language when discussing more emotional topics?
Oh, like what would I say? So sometimes I might say, let me think about how I've done it, because I worked with an Iranian American student who spoke Farsi. Say, kind of with this curiosity, I'm sensing that there's a word that maybe isn't in English that you want to say. Is there a word in Farsi that is coming to mind? Where she's kind of pausing, she gets this look in her eye like she's thinking of something else, and then she says, yes, there's this word in Farsi. I said, why don't you just tell me what you're thinking in Farsi? Just say it in Farsi. I know I don't speak Farsi, but then we can talk about what that means. And so that can be that bridging moment. And sometimes it's like us being aware of, sometimes it's like, oh, there's some other, it's like a different language underneath the English. There's this substrate of another language that I tap into, or think that, oh, there's something else going on. But another way is to be very psychoeducational and to say, sometimes emotions are experienced differently in different languages. And I know we've talked a lot about your mother and how you lost her at a young age, and you only spoke Spanish with your mother. And I'm just wondering, what is it like to only talk about her in English? And what would you say to her? How would you describe her to me in Spanish if that were the case?
Mm-hmm. Thank you. Perfect. Okay. So we have time for 2 more questions.
Great.
Thank you, and a comment. Thank you so much for your valuable insight. How beneficial is it to acknowledge the non-Latino provider's privilege in relation to the client? Do you think it would enhance the therapeutic relationship?
I think it depends on the context. I think if I go in and I'm like, I'm so privileged compared to you, that can come off a little actually paternalistic. It could also bring attention to things that maybe are not forefront in the patient's mind yet. But certainly acknowledging something like, I know I haven't had the same experience as you do, but what's it like to talk about it with me? So I tend to focus it more on the therapeutic relationship that I have, rather than on categories that I belong to or perceive myself to belong to. So rather than me saying like, what's it like to work with a white clinician? Because that can be a little off-putting. People might say like, well, what do you mean? Like, you're not just any white, you're my clinician and we have a relationship. So focusing on what's it like to work with me, knowing that I might go home and that I have a house, or you come into my office and you're hungry and you know that I'm not hungry. What's that like? Mm-hmm. Really ground it more in the experience. And also I find, and I work with university students, so a lot of the students I work with now, they're sociology majors. They're talking the language of social justice and privilege and marginal identities and social exclusion. But most of the patients I worked with previously, they weren't college educated. They might not have even had a high school degree. And so there's also privilege in like using these categories or calling it like putting too much emphasis on or assuming that our patients need to be sociologists as well.
Okay, thank you. And our last question, how do you assist the patients whose family system may not believe in psychotherapy?
It's like the age-old question, right? Well, a lot of family systems, including white Anglo, don't believe in psychotherapy. So I think I go back to, can I establish rapport? Can I offer something concrete? Maybe your family doesn't think you need therapy. Maybe you don't think you need therapy. So, but you're coming for some reason. What can I give them so that they feel like there's something? Can it be, maybe it's not a traditional structure. So I had a supervisor, Mexican-American supervisor, who would just tell patients like, hey, we're just going to meet like 6 times and we'll see how you feel. Vamos a platicar. We're just going to talk. So present it not as this big formal clinical undertaking, but rather like, oh, we'll just meet and see what's going on, how you like to talk. So you're not making them commit to long-term psychotherapy. You're not making them commit to medication, but like, let's just see how it is. If you come and talk to me, sometimes people find it helpful to talk through what's going on in their lives.
Mm-hmm.
But if other people have other suggestions, I would love to know that. I'm usually in the position where I'm working with college students who come in and they say, my parents don't believe in psychotherapy, but I need it and I'm here. So that can be a little different because they're also establishing their autonomy. They're willing to have some rebellion since they're not physically living with their parents. And developmentally, they're at that stage when they're saying, you know, I need to make some choices for myself and be more autonomous.
Mm-hmm. Thank you so much. So that's all the time we have for now. So I want to thank you, Dr. Maynard, for your presentation and taking the time to do this presentation for us. We truly appreciate it. And for our audience, just to let you know that there's going to be a recording of today's webinar on our website as well as our YouTube channel. So if you missed part of the presentation, you may access that. And also, as we finish today's webinar, you'll be redirected to complete a brief survey and an evaluation. So we truly appreciate that you take the time to complete the evaluation, because that is something that will give us the opportunity to continue to do trainings and webinars such as this one. So again, thank you everybody for participating, and thank you, Dr. Maynard.
Thank you so much for having me.